I'd like to give a big welcome to our healthcare executive panel.
We're very fortunate to have 5 of the state's leading CEOs with us, who I understand are ready to unveil all their trade secrets and strategies that fix healthcare. They're also going to provide some, I know, some great perspective on the challenges and changes facing the industry.
I think we have to start aligning incentives better, and as insurers start finding ways where there's a lot more order, there's a lot more safety around trying new things. We didn't get here overnight, we're not going to get out of it overnight, but there's tons of things we can do. Remember also there's a large continuum between, you think back to the old fee-for-service and capitated, there's a lot of range in there for value-based payments that can surround a lot of different things, price, quality setting, location, all of those things. It's very complicated. We're not going to get there overnight. I think what we're trying to do is make the first steps, and even those are hard, because it's hard to define what success is and where the value is.
Well, I think we're well on the way of making changes in our healthcare delivery system. I think the ACA really did stimulate some pretty significant changes in our industry, both healthcare and health insurance. And because of that, I think providers, whether they call it population health or other names, have really made the decision that we really do have to add value and improve quality, take out cost, and so I'm very optimistic, and I think that the integrated delivery systems in Wisconsin in particular have focused on value, and today it's a completely different day than it was even 5 years ago. As Mike says, it's not going to happen overnight. It took us 30 years to create a fee-for-service system to get us to this point in time. You're not going to make these changes in 1 year or even 2 years. It's going to be an evolution with, I think, the winners being successful at creating value.
I think the right conversations are happening, though. People are starting to talk about how do we drive value, how do we reward higher value care and lower cost. And so the right conversations are happening. I think one of the other sticking points that people are working through is that there are questions about what data do you actually use to define value. And so there are a lot of clinical measures, or a lot of things that you can get from your claims data, which may or may not actually equal value. And so a lot of times what we call value ends up being utilization control again.
Also, I think some providers are kind of weary of the BVR. They see it as a form of capitation. For most of our providers, even though they're embracing managed care.
I'm going to make it my job to stir the pot here. First of all, I'm kind of running out of patience. I think a lot of people are. Having said that, the system is exceedingly complicated and difficult. So, yes to all of what's been said, but we're going to figure out how to pick this process up and accelerate it. Well, I think by and large it's a good thing that we have a competitive market. Unfortunately, some of the recent acquisitions are reducing, and consolidations are reducing the competitiveness of the market in Wisconsin and everywhere else. Not only is Wisconsin competitive in sort of the number of players, but also it's a little bit unique in terms of the kinds of players. We have a lot of not-for-profit and provider-owned, as well as sort of traditional national investor-owned plans. I do think fundamentally that is a good thing. I also think that competition is better on the healthcare side. I think less consolidation in insurance is good, and less consolidation in healthcare is also, I think, fundamentally good. The best, the most competitive healthcare market in the state is along the eastern part of the state, particularly in Molina. And I think, based on what we pay, we see that that's actually good for costs. So I think competition in insurance and I think competition in healthcare are good. I think consolidation in both is not a good thing.
Well, with fewer insurers having more members per insurer, we certainly would be able to negotiate lower provider reimbursement rates, and actually, I think, be able to move faster to that BVR model that you're talking about. When providers have such a large payer mix, it does tend to drive up the cost of reimbursement, which can drive up premiums.
I think there's a difference between competition and fragmentation. And I think we have a very fragmented market, which is different from a very competitive market. We need balance. And it is, I think the providers like a fragmented market because there's not a heavy hand that can, I don't mean just drive down price. I mean, that's where I think you have to be careful about the conversation. It's about driving innovation. It's about providing data across a wide cross-section of the population. I mean, there's lots of different pieces and parts on it. And when there's, it's kind of like trying to keep track of a whole class of kindergartners versus one or two of your own. I mean, it's just hard to manage when there's that many. And so I think we need a balance, and we're over-balanced on the fragmentation side.
I think one of the mistakes my industry made many, many years ago was thinking you could micromanage healthcare from the outside, that health insurers can really change the way healthcare is being practiced. And I think we're going to have to get out of the way. I think doctors and hospitals are going to have to re-engineer how they do business, and that's going to take a fundamental change in how we fee them. I mean, we've been paying a fee for service. It just incentivizes more utilization. And today, I think having a fragmented market, we're seeing experimentation, we're seeing global budgets, and at the end of the day, you're going to have to say to folks, here's how much money you get, figure it out. I think competition is good because I think it's going to stimulate a lot of changes in this state over the next 5 years.
There are some benefits. I think there are also some drawbacks to consolidation. If you have a consolidated market and you have a group that is driven by quality, focused on the triple aim, that can facilitate better care. I think also, though, it takes away a measure of choice within the marketplace as well. And so I think consolidated larger groups really need to focus on the things that are best for the patients.
Yeah, we introduced earlier this year StatDocs, who has since been purchased by Teladoc, for our employees and offer it to our employee groups. We did a couple of fun things, and John Stevens from our shop is in the audience, and he's the one who kind of engineered this whole thing. In both a management meeting with 300 people in the room and a board meeting with, 15 people in the room, we did a virtual visit with a doctor, and it really works slick. But it's really about convenience. And meeting your customer where your customer needs help. When you think about how busy everybody is it for everything, right? If you have a really bad diagnosis or something, you're not going to want to do that. But there are sometimes you just want to know, you just want to check. You're heading out on vacation or a trip, business or personal, whatever, and you want to know, is this okay to go on that? Or you need a refill on a prescription on certain times, and it's a convenient way to do it. It's just one more delivery mechanism that's going to work in some situations.
Terry, where are you guys at with telehealth?
So we're all in on telehealth. Unity helped UW fund its e-visits behind its portal. We sit behind the portal also. So about 2 years ago, we actually helped create the technology to do that. Today, they're in the process of introducing telederm, and one of our biggest challenges is getting people in to see dermatologists. But it's a very visual type of medicine. So you can take a picture with a smartphone, and then people will be able to take a picture with a smartphone, upload it into MyChart, and have a dermatologist read it. The beauty of that being that you can move the melanomas to the front of the line. You have a lot of referrals from primary care docs who really don't understand skin. And by taking a picture and sending it in, you can really change the practice of medicine in a very positive manner.
We're all in with telehealth as well. We're also doing telederm, but a couple of years ago, or just over a year ago, we introduced Virtuel, which is actually designed by health partners in the Twin Cities. We offer that to all of our members, and it's essentially an online clinic. I think that it's only logical that we would find a way to use this technology to interact and connect with the patients.
Molina nationwide is using telemedicine. We haven't adopted that quite yet here in Wisconsin. Being largely a Medicaid organization, we're very interested in seeing the current bill and seeing how that goes through because that'll have a direct effect for us. I think one thing also just to share is the value of telemedicine in behavioral health, particularly in rural Wisconsin.
I think telehealth is a very positive development. I'm glad to hear that we're all moving in that direction at various paces. We are as well. I think it's a big convenience factor. I think it's certainly suitable for many primary care conditions. It's better for the patient. It's going to cost less overall. I think that's positive. I think it's going to help improve quality, improve outcomes and have prevent lower costs.
Thank you guys so much for coming. Thanks for a great panel, for a great discussion today.